Great, thank you. Okay, welcome back from lunch, everybody. I hope many of you were able to get outside and enjoy some of the nice weather and the nice views. Wanted to start off talking a little bit about Section I and Section J, which have some new items starting in October. So as with all of the other presentations, there is a list of acronyms at the beginning of this presentation that are being used. There's also a list in your packet if you're interested in looking up something. In terms of overview, the intent of Section I and J will be described, and so it's my hope that after this presentation you'll be able to explain the intent of those two sections. It's also my hope that you'll be able to define the item I-020, which is indicate the resident's primary medical condition category, and item J2000, which is prior surgery. Did the resident have major surgery in the 100 days prior to admission? Also, it's my hope that you'll be able to discuss some coding instructions for those two items, and we will also be doing a review of some practice scenarios together. One thing I did want to mention is that the slides that were posted before today were meant as helping you get ready, and so you don't have the answers in the slides yet. Today, obviously, when I present, just like Terry, I will provide the answers and the rationale. Those slides with the answers and rationale will be posted after the training. So I wanted to be sure that you were aware of that. You will get that information available, but we just, the Econometrica CMS team didn't want you to have that before the presentation so that it would provide a little bit of time for you to think through that. I think the other thing that I'd like to highlight is that the Econometrica team is pulling together all of the questions, and there will be a Q&A discussion later today and also one tomorrow. And so if you submit questions under the questions, that makes it easier for the team to kind of pull those together. There's a separate tab for ideas, so if you can keep the ideas to the ideas tab and the questions to the questions tab, it will just make it easier and more likely that your question might get answered during the session today or tomorrow. So thank you. Okay, so again, the objectives, it's my hope that you'll be able to identify the intent of these sections, you'll be able to do some practice, and you'll be applying some of the coding instructions for these two items. So we're going to begin with Section I, Active Diagnoses. And for this section, the intent is that you are to code diseases that have a direct relationship with the resident's current functional status, cognitive status, mood or behavior status, medical treatments, nursing monitoring, or risk of death. One of the important functions of the MDS 3.0 assessment is to generate an updated, accurate picture of the resident's current health status. So going into this item more specifically, that is item I-020, indicate the resident's primary medical condition. This is what it looks like on the actual data set. And so you'll see that this is at the beginning of this section, and the instructions say indicate the resident's primary medical condition category that best describes the primary reason for admission. And it is only coded on the admission assessment, and we'll be going through the categories together. You'll notice that there's a box to enter the 2-digit codes, and then in the event that you code 14, as in those boxes, there is an item that is a space to enter an ICD code. So we'll talk about that again shortly also. Okay, so the rationale for this particular item relates to health-related quality of life. So obviously, as you know, disease processes can have a significant adverse effect on a resident's functional improvement. And so in terms of planning for care, this item identifies the primary medical condition category that resulted in the patient needing to be admitted to your skilled nursing facility and would influence the patient's functional status and their outcomes. So this item was added because it is a risk adjuster for the Skilled Nursing Facility Quality Reporting Program functional outcome measures. So in case you're not aware, under last year's rulemaking process, CMS proposed and finalized adoption of 4 functional outcome measures, and those are listed on the slide. These quality measures were actually adapted for the skilled nursing facility setting, and they are similar to the quality measures that were adopted previously in the inpatient rehab facility quality reporting program. And so the modification is why we call these an application measure for functional outcome measures, the first one being change in self-care for medical rehabilitation patients. This is a quality measure that is endorsed by the National Quality Forum. You have all the NQF numbers here if you're interested. The second measure is called discharge self-care for medical rehabilitation patients. The same items are used to calculate these measures, but they are calculated in different ways. The third measure is change in mobility for medical rehabilitation patients, and the fourth measure is discharge mobility score for medical rehabilitation patients. So when coding this new item I-020, you will be reviewing the documentation in the medical record to identify the resident's primary medical condition associated with admission to the skilled nursing facility stay. Sources of information from the medical record could include the most recent history and physical written by a physician, any transfer documents, discharge summaries from acute care, progress notes, or other resources is available. Certainly, the acute care data will be very helpful because many of the diagnoses that are listed are really the reason that somebody probably was admitted to an acute care hospital prior to being admitted to the skilled nursing facility stay. So for example, you probably noticed stroke as one of the examples. So a resident may have been admitted to get acute care following a stroke, and then they are admitted to perhaps a skilled nursing facility as a result of the consequences of the stroke, perhaps some paralysis, some aphasia, perhaps a swelling problem. And so stroke would be, in that case, the underlying diagnosis. So I will be reviewing just briefly in the next couple of slides the list of diagnoses, and then we'll go through some examples together. So the first diagnosis is stroke. The second is non-traumatic brain dysfunction, traumatic brain dysfunction, non-traumatic spinal cord dysfunction, traumatic spinal cord dysfunction, progressive neurologic conditions, other neurologic conditions, amputation, hip and knee replacement, fractures and other multiple trauma, other orthopedic conditions, debility and cardiorespiratory conditions, medically complex conditions, and other condition, which is used when none of the other categories apply. So in terms of coding instructions, so as I mentioned previously, this is only coded on the Part A PPS stay admission assessment. So that would be if A0310B is equal 01. You would enter the code, again, that represents the primary medical condition that results in the resident's admission. As you're used to with all the other items, if you have 2 boxes, you're entering 2 numbers. So if the code is 1, you're actually entering 01. If the codes 1 through 13 do not apply, you would enter 14, which is the other category, and then you would proceed to the follow-up item, which is I-020A. Include the primary diagnosis condition in this item I-020, as well as in section I-010 through I-8000 active diagnoses in the last 7 days. So for example, if you are coding stroke as a primary diagnosis, please also check it below as a comorbidity also, because there's multiple uses of these data. Okay, just getting into the details a little bit more in terms of this particular item. So code 1 is used if the person has experienced a stroke. And so the examples that we have, just to give you an idea of what that is, just a little bit more in depth than the name. So it include ischemic stroke as well as hemorrhagic stroke, such as a subarachnoid hemorrhage. You might also see cerebral vascular accident listed or other cerebral vascular disease. I know sometimes I'll see in records TIA, but oftentimes somebody might have actually had a stroke after that, so you'd be looking for the stroke. Because if somebody had a TIA, they're probably not being admitted for a TIA. The second category, so this would be coded O2, is non-traumatic brain dysfunction. So examples of non-traumatic brain dysfunction diagnoses would include something like Alzheimer's disease, dementia with or without behavioral disturbances, malignant neoplasm of brain, perhaps with or without surgery, or perhaps anoxic brain damage. And so, that could obviously have quite a few causes, but that would be the diagnosis. Code 03 is used for somebody who has had a traumatic brain dysfunction. And so that would include a traumatic brain injury, a severe concussion, laceration, or contusion. So this could be perhaps as a result of a car accident or other traumatic event where the person maybe fell and hit their head. Code 4 is used to indicate that the person has had a non-traumatic spinal cord dysfunction, and that would include things like spondylosis with myelopathy, transverse myelitis, spinal cord lesion due to spinal stenosis, and spinal cord lesion due to a dissection of the aorta. Perhaps there's been an infarction of the spinal cord. Code 05 would be coded if the person has had a traumatic event that led to a spinal cord injury. So again, could be as a result of a fall or a car accident where the person has experienced damage to their spinal cord. Code 06 refers to progressive neurologic conditions. So there are many types of conditions. So we've listed multiple sclerosis, Parkinson's disease, ALS is another example. Code 07, other neurologic conditions would be those that are not progressive, and so that could include something like cerebral palsy, polyneuropathy, myasthenia gravis. Code 08, amputation is related to an acquired absence of limb, could be upper or lower extremity. Code 09 is used for hip and knee replacement, and so here, an example, obviously, knee replacement or hip replacement. And one of the things that I did want to highlight here is that we are interested in hip and knee replacements that are not due to a fracture. And so as you may have noticed, there is a separate code for fractures and other trauma. And so if the person has had a hip fracture and then part of the treatment was a hip replacement, you would actually code that as a hip fracture. And the rationale is that the types of patients who experience a hip fracture have a different clinical profile, demographic profile, and also functional outcomes are different for somebody who has kind of this unexpected hip replacement due to a hip fracture as opposed to somebody who perhaps has had a planned hip replacement and is getting post-acute care. So again, the reason for the items being added is that we are using these data to risk adjust functional outcomes, and so that's why that was kind of an important distinction. And I really appreciate that somebody actually submitted that as a question already, so that's a great thing to highlight, and I appreciate that somebody was really paying attention, even before I got to present. Okay, so the next one is actually fractures and other multiple trauma. So in this case, the hip fracture, person who had the hip fracture would be coded here. Also, other types of trauma could be pelvic fracture, fracture of tibia, fibula. Code 11 is used if somebody has had some kind of orthopedic condition that isn't already covered under the hip replacement or hip fracture. So this could be some kind of joint disorder or maybe some kind of osteoarthritis of some type. Code 12 refers to debility cardiorespiratory conditions. So these are conditions where somebody probably has really poor endurance, so it's difficult for them to walk for long distances or maybe to go up and down stairs. And so examples of these would be any kind of cardiac or respiratory condition or kind of an accumulation of those kinds of conditions. So it could be somebody with COPD, somebody with asthma, other malaise, fatigue. So this can be kind of a broad category, but the common theme is that these individuals have some kind of endurance problem. Number 13 is kind of a wide-ranging group. We call it medically complex. And so this can include the residents who have conditions that have maybe accumulated. There's a few things going on. So perhaps the person has diabetes, pneumonia, chronic kidney disease. Maybe they have all three of those together. Somebody with open wounds, pressure ulcer, some kind of infection maybe that has led them to become needing some skilled level of care, and they're not quite ready to go home after an acute care stay. Disorders of fluid electrolyte or acid-base imbalances. And then number 14, anything that hasn't been covered by the categories that I just described would be reported in 14 other medical condition. So again, if this item is coded 14, this other medical condition, we ask for an ICD-10 code to be entered in I-200A, or I-20A, sorry about that. And if you are not using 14, you do not need to code this particular, the ICD code. So if you're coding stroke or hip replacement or fracture, then you do not need to enter an ICD-10 code. Okay, so we have some practice scenarios, and so similar to what Terry did earlier today with DRR, we will go through practice scenario together. I'll give you a few minutes to enter your answer on Slido, so please pull out your phones or your laptops so that you can participate, and that includes anybody who is following us online. And as I said before, we will provide obviously the answer today and the rationale. If you're looking for these slides, those will be posted at a later date with the answers. Okay, so the first coding example here is Miss K is a 67-year-old female with a history of Alzheimer's, dementia, and diabetes, and she's now admitted following a stroke. The diagnosis of stroke, as well as history of Alzheimer's, dementia, and diabetes, is documented in Ms. K's history and physical by the admitting physician. So we have a physician diagnosis here, as well as some comorbidities. And so I'll give you a minute to think about what might be the primary diagnosis. I'll also remind you that if you want to look at the practice scenarios, you do have this in your packet, whether you are here in person or you're online. You can look at your packet. There's scenarios. So I think the section I and J start on page 6 of your coding. I think it starts with GG, and then which we'll be covering tomorrow, and then it's got section I on starting about page 6. Okay, so how would you code this resident? So the person has a history of Alzheimer's, diabetes, and some kidney issues. They're admitted after having a stroke. Okay, so I see a few people are entering their codes. I'll give you a minute. There seems to be a preference. I'll just wait another little bit. Okay, so it looks like most of you coded stroke, and I do agree with that. So stroke is indeed the correct answer. I think I did see maybe a couple of people who wrote medically complex. So in this case, because we did say that the person was being admitted for the stroke and they happen to have comorbidities, it would meet the criteria for stroke. I think probably every resident you admit have lots of diagnoses. So in this case, there's a clear reason, or we try to describe a clear reason why the person was admitted, and that being the stroke. So again, the rationale, it specifically stated in the example that there was a physician documentation in the history and physical that there was a diagnosis of stroke. Okay, so practice case scenario 2. Mrs. H is a 93-year-old female with a history of hypertension and chronic kidney disease who is admitted to your skilled nursing facility where she will complete her course of IV antibiotics after an acute episode of urosepsis. The discharge diagnosis of urosepsis, kidney disease, and hypertension are documented in the physician's discharge summary from the acute care hospital and are incorporated into Mrs. H's medical record. So again, there's physician documentation, and there's a few conditions that this person is being admitted for related to urosepsis, kidney disease, and hypertension. So how would you code I-020? The options for this particular example are 12, debility, cardiorespiratory conditions, 13, medically complex, and 14, other medical conditions. Okay, so I see people are still entering. As you can see, there is a preference. So we'll just wait for a few more people to be able to answer. I think people who are online, there's maybe a bit of a delay here, so I want to be sure they have time to enter their responses. Okay, so I think we can agree that the correct response is indeed 13, which is medically complex. So it is true that somebody who has lots of those things going on may develop debility, but in this case, there wasn't mention of debility being an issue for this particular person. So without specific documentation of debility, the constellation of the urosepsis, the kidney disease and hypertension led us to the medically complex category and code 13. Great. Okay, so again, the rationale, the physician's discharge summary from acute care hospital documents and the need for IV antibiotics due to urosepsis as the reason for Mrs. H's admission to the facility. Okay, we have another example here to go through together. This is actually the last one, and I did kind of give you a hint a long time ago, and so we wanted to be sure this point was emphasized. I think I did emphasize it before. Mr. T is an active 83-year-old male who fell from a ladder while changing a ceiling light bulb at home and sustained a left intercapsular hip fracture with subsequent total hip replacement. The discharge diagnosis of status post hip fracture with total hip replacement are documented in the physician's discharge summary from the acute care hospital and are incorporated into Mr. T's medical record. He is admitted to the SNF for rehabilitation. So again, this is an instance where somebody experienced a hip fracture due to an accident and then had a hip replacement due to that hip fracture. And so how would you code this particular resident if he was admitted to your skilled nursing facility? The options here are 09, hip and knee replacement, 10, fractures and other multiple trauma, 11, other orthopedic conditions. Okay, I'll just give everybody a bit of time to put in an answer there. Okay, it looks like most people are coding 10, and I do agree with that. So again, in this instance, this gentleman did have a hip replacement, that is true, but if you remember, I mentioned before that if the reason for the hip replacement is actually a hip fracture, you would code the hip fracture as a fracture. And so the correct response is 10. The other orthopedic conditions, I think a couple of people might have coded that. So other orthopedic conditions would be things other than a hip replacement and other than fractures of bones. So again, the full rationale is here. Per coding instruction 09, hip replacement. If hip replacement is necessary, is secondary to hip fracture, please code the hip fracture. Okay, so now I want to move to section J, health conditions. So there's one new item in this section that I wanted to review in the next 10 or 15 minutes. So in terms of section J, this is a section that is familiar to you, and as you may recall, the intent of the items in this section are to document health conditions that impact a resident's functional status and quality of life. The items include an assessment of pain that uses an interview with the residents or with staff if the resident is unable to participate. The pain items assess the presence of pain, pain frequency, effect on function, intensity management, as well as pain control. Other items in this section relate to other topics related to quality of life, such as dyspnea, tobacco use prognosis, problem conditions, and falls. The new item that is being added is item J2000 called prior surgery. And this is just a simple question that is yes, no, or unknown in terms of did the residents have major surgery during the 100 days prior to admission to the skilled nursing facility. So if you are able to ascertain this information, the answer would be no or yes. In the event that you've tried to get the information but you're unable to get the information, please code unknown. You could enter a dash into this item. However, as I think Terry and perhaps Deb mentioned earlier today, dash use is not encouraged. It should be rare. And so you have the opportunity to basically say unknown in this instance. So in terms of the rationale, this was added because a recent history of major surgery during the 100 days prior to the resident's admission to the skilled nursing facility can affect the resident's recovery. This item can be used for care planning as it affects the patient's or the resident's recovery. And as I mentioned before, as part of the adoption of the functional outcome measures, our analyses found that individuals who had had prior surgery in the 100 days prior to a post-acute care stay had different outcomes if they had surgery or not, and so it is a risk adjuster. So as I mentioned, the 4 outcome measures are tied to this item. Again, it's a risk adjuster for these 4 functional outcome measures. I'm not going to read the names again, but it's the same ones that I mentioned previously. So the steps for assessment for J2000, so you would ask the resident or family or significant other about any surgical procedures in the 100 days prior to admission. In the event that somebody experienced major surgery during their acute stay immediately prior to your admission, the resident's admission to your SNF, then obviously you would have the answer there already. So for example, the gentleman who had the hip fracture and hip replacement surgery, that would be major surgery, and you would code it based on the acute care record. In the event that the person didn't have major surgery and acute care, you might be, again, interviewing the resident or family for information. So it could be based on self-report, or in terms of the second example here, the medical record could be used to determine whether somebody had major surgery or not. So source of information could include the medical records, most recent history and physical, transfer document summary, discharge summaries, progress notes, and then other resources is available. As I mentioned, coding instructions, you would code no if the resident did not have major surgery during the 100 days prior to the SNF admission. Code 1, yes, if the resident had major surgery during the 100 days prior to admission. And code 8, unknown, if it cannot be determined if the person had major surgery or not in the last 100 days. So we do have a definition that's been added to the manual. Generally, major surgery for item J2000 refers to procedures that meet all of the following criteria. 1, the resident was an inpatient in an acute care hospital for at least 1 day in the 100 days prior to the SNF admission. The resident had general anesthesia during the procedure. And 3rd, the surgery carried some degree of risk for the resident's life or the potential for severe disability. So it was significant. So we have 3 examples to go through. And there's a bit of variety here. So the first example, Mrs. T reports that she required surgical removal of a skin tag from her neck a month and a half ago. She had the procedure as an outpatient, and she reports no other surgeries in the past 100 days. So how would you code Miss T? Did she have major surgery, the skin tag? Would that be considered major surgery? During the 100 days prior to admission. So I will give you a minute to start answering. And it looks like there's a direction of no. All right, we'll just let others online, as well as everybody here in the room, provide the answer. So there's no way I can disagree with 100%, right? So I do agree with you. So the answer in this case is indeed a no. And I will get that checkbox up there. And again, the rationale, you could probably tell me a skin tag is not major surgery. Second example we have for this J2000, Mr. A's wife informs his nurse that 6 months ago, he was admitted to the hospital for 5 days following a bowel resection, partial colectomy for diverticulitis. Miss A's wife reported that Mr. A has had no other surgeries since the time of his bowel resection. So remember, one of the criteria is the last 100 days. So there's the major surgery part, but then there's also the 100 days to take into consideration. So I will let you tell me if this is major surgery during the 100 days prior to admission. The response options are 0 no, 1 yes, 8 unknown. You can change your answers. Again, there's 100 days. So if it happened 6 months ago, it's not going to meet the criteria. Okay. All right. Looks like most people coded 0 no. And I do agree with that. So again, it is major surgery, but the time frame is what was really important here, that it didn't happen within the 100 days. And so, again, that is in the rationale spelled out. Bowel resection is major surgery requiring general anesthesia and has some degree of risk for death or severe disability. So for the few of you who said yes, you were correct, it's major surgery. But in this case, the fact that it was 6 months ago is the reason that we were coding this one no. Okay, last example in this segment, Mrs. G was admitted to the facility for wound care related to dehiscence of a surgical wound subsequent to a complicated cholecystectomy, for which she received general anesthesia. The attending physician also noted diagnoses of anxieties, diabetes, and morbid obesity in her medical record. She was transferred to the skilled nursing facility immediately following a 4-day hospitalization. So if you think about that definition of major surgery, we talked about being in the hospital, we talked about general anesthesia, we talked about concern about potential risks. So I think there's some comorbidities here that you're probably paying attention to. So I will let you provide an answer on this one. The options are, for this particular person, no, the person did not have major surgery in the last 100 days, 1 yes, or 8 unknown. Okay, so we're starting to reach about 200 people entering. Okay, looks like 95% of you did indeed code the correct answer, which is 1. And so I will get my little checkbox up there for 1 for you. And then again, the rationale is that she had this surgery. She did have general anesthesia, so it did meet that criteria. She had all these comorbidities. We put her having morbid obesity to make it sound kind of risky. And then she was in the inpatient, and it did happen within the last 100 days. So you are correct on that one also. So just in summary, in this presentation, you learned the intent of the sections I and J. You got introduced to the two new items, one being primary diagnosis, one being major surgery. Again, these items were added because they're risk adjusters for the new functional outcome measures, and we went through some examples together to apply some of the coding. So with that, I think maybe we'll share some action plan ideas before Tom comes up. So let's see, I'll read the short ones, because I do have a few minutes. So let me read the first one. Education of physicians regarding the need to carefully discuss, and nurses, all new admission medications and the need for a diagnosis for all drugs. Okay, excellent. Also, nurses need educated to have a discussion on admission with residents, representatives, and families of drugs taken. So that relates to the drug regimen review. I'm sure Terry is very happy to hear you say that. We'll need to have a discussion with our partner hospitals about what information is necessary for the MDS and to be compliant. So it's always great to have communication across settings when residents are being transferred, so that's terrific. Suggest adding ICD-10 code for other orthopedic aftercare following surgery to capture traumatic fracture aftercare. Once fracture is reduced, repaired, replaced, then we will no longer treating the actual fracture during healing phase. We are then treating the surgical aftercare. So that is correct. That's actually a really good point. For all of the diagnoses that are listed in the new section I, you are treating the consequences of the post-surgery care, the consequences of a stroke, the consequences of the traumatic brain injury or spinal cord. So yes, indeed, we've now kind of transitioned to providing care for the consequences, but understanding the underlying condition is really important when we think about functional outcomes. So did the person experience a stroke and have neurologic problems after that and maybe some weakness, or did the person perhaps have a fall or some orthopedic condition and has weakness, and so their trajectory does tend to vary. Okay, just gonna read a couple more. Review admission nurse assessment for questions regarding surgery in the last 100 days, hospitalized. So that sounds good. Add question about surgery to baseline CP review. I'm not sure what CP is. What's care plan, sorry. Okay. If a facility is unable to complete drug regimen review, okay, well, that's for Terry later. All right, I think I will end then at this point. So thank you very much for your attention, and I will see you tomorrow with section GG.